Gender Equality and Safety Research Group seminar. Really pleased to see so many of you joining us here today. My name is Daisy Halligan and I'm a research fellow working in the Quality and Safety Research Group. Our director, Professor Rebecca Lawton, usually chairs these seminars, but unfortunately she's unable to join us today. So I get the pleasure of introducing our speaker, Dr. Phoebe Averill today, who I've known for several years because both of us completed our PhDs funded by this institute. It's really lovely to see so many people here today from different organisations. So welcome everyone. Just to give you a bit of background about Phoebe. Phoebe completed her PhD in mental health services research at King's College London and is now a mixed methods researcher within the North West London Patient Safety Research Collaboration based at Imperial College London. Phoebe's research interests broadly are in conducting work which helps to understand and improve the safety and quality of healthcare, with a particular focus on those at heightened risk of poor care, such as people with mental illness or learning disability. Although Phoebe's disciplinary background is in psychology, her day-to-day work in applied healthcare services research borrows from multiple disciplines and approaches. She enjoys collaborative, participatory methods, but is also interested in conducting research which harnesses insights from routinely collected data. So today, Phoebe is going to speak to us about some of the research she conducted during her This Institute-funded PhD, in which she aimed to study the nature of patient safety problems in community-based mental health care to identify priorities for future interventional research. So before I hand over to Phoebe, I just want to encourage people, if you have any questions throughout the seminar, if you could pop them in the chat function, that would be great. And then once Phoebe's finished her presentation, I'll direct Phoebe to certain questions. If you could please put your microphone on mute for now, that would be fantastic, please. And just to let you know, the session's being recorded and will be on our YouTube channel at YQSR. But that's all for now, so thank you, and I'll hand over to you, Phoebe.
Daisy, I will just share my screen. Hopefully that's showing okay. Brilliant. Okay, thanks very much, Debbie and Daisy, for the introduction and for stepping in to chair the meeting. I really appreciate it. As Daisy mentioned, my name is Phoebe Averill, and currently I'm based at the North West London Patient Safety Research Collaboration with a great group of people researching a wide range of patient safety and quality problems. And prior to that, I was down in South London at King's researching patient safety in community-based mental health services. And that's the work that I've been asked to speak about today. So I'll get straight into it. So I understand that most of us on the call will have an interest in patient safety and quality, but perhaps not everyone will be familiar with the context of mental health services where things look a little bit different. So just a little bit of a history of the field and how it applies to mental health. So when we think about patient safety, many of the kind of models and theories and definitions that we use are derived from physical healthcare settings, and they don't necessarily always apply quite so well to thinking about the mental health care context. Mental health services have historically been missed out of many of the key publications about patient safety, so the ones that have really changed the field. Oh, sorry, I don't know what happened to my slide then. Patient safety and mental health care has only really been considered as a field in its own right more recently. So there's a brilliant paper by Danielle de Lima and colleagues that really outlines how the fields of patient safety and mental health services research have really developed quite separately and in silos, and haven't really referred to one another or developed in unison. And really what that means is that the field of patient safety and mental health services, as it's developed, there's been a real focus on kind of public safety and, risks to self and others, rather than our traditional sense of what patient safety means. So when we think about patient safety traditionally, we don't really think of service users being the origin of risks, which is how they've been positioned in the kind of development of this field in the context of mental health care. Really, there's been a kind of widespread overlooking of factors such as the system problems and other iatrogenic harms, which may stem from the processes of mental health care itself. And this has only really changed a lot more recently. So when we look at the kind of research in this space, it's been quite narrowly focused around suicides and self-harm and rare acts of physical violence and aggression. And these are very important issues to recognise, of course, but we need to make sure that it's not at the expense of also recognising the harms that come from the process of mental health care itself and the kind of improvements which should follow. Fortunately, this is beginning to change with research from the Patient Safety Translational Research Centres and now the Patient Safety Research Collaborations. So we've seen some really important research coming out in this space, which has helped to really drive forward what the kind of wider harms are in mental health care. So a more recent picture of patient safety in the context of mental health services. Well, a mental health trust was the first ever to be prosecuted under new legislation brought in following the Francis report, and this was for providing unsafe care. We know that 40% of NHS trusts that provide mental health care were rated in 2018 as inadequate or requires improvement for patient safety. But we're also seeing a huge reduction in the numbers of mental health inpatient beds since the turn of the millennium. So a reduction of 56%. And what that means in terms of the population is in the year 2000, there were 0.92 beds per 1,000 members of the population. And in 2022, which is when the most recent figures were released, that had reduced to 0.35 beds. So it's really quite substantial. And what this means is that community-based mental health teams are now dealing with larger caseloads of service users who are increasingly unwell. It was really welcome to see that the NHS Mental Health Safety Improvement Programme, which was a national programme focusing on improving safety in mental health services. It was great to see a kind of explicit acknowledgement that there are patient safety problems in mental health services, but it was rather disappointing to see that this focused only on inpatient mental health care settings, on a range of issues including reductions of self-harm, reductions of physical restraints and improving sexual safety on the wards. It was disappointing to see that that community-based provision, where the majority of service users are receiving their mental health care, weren't considered within this remit. And I suppose the crux of the point is that we can't really presume that the patient safety problems and the routes to intervention are the same across all mental health care settings, when the contexts of care are really quite different. So more recently, the Health Services Safety Investigation Body carried out an investigation into patient safety in community mental health teams, and this brought a really welcome focus on the patient safety challenges which are inherent in community-based mental health care. And of course, this has gathered a lot of media attention recently, given the very tragic events in Nottingham involving Valdo Calacane, who was discharged from his community mental health team in advance of carrying out several very tragic homicides. So this has really brought the challenges into the spotlight that community mental health teams are facing regularly. So for my PhD research, I aim to understand the nature of the patient safety problems in community-based mental health services and the contributory factors. I also sought to understand any priorities for intervention development. And as part of this, I focused on any community-based mental health care setting within primary or secondary care. And the reason for including primary care was really in response to our patient and public involvement panel, who felt very strongly that for many service users, actually support from a GP, be it with medication management or other aspects of care, is really the only care that's available to many people, given that there's a drive to discharge people from secondary care mental health services. I focused on working age adults for this work. There are different problems facing children and young people, but also older adults. but I really didn't feel like I could do all of that justice in the context of the PhD. So I carried out a couple of evidence reviews, mixed methods, incident data analyses, and qualitative interviews and focus groups, and triangulated the source of information. So I'll give a bit of detail about those in the following slides. So the first study that I completed, but not the first study that I started, was a narrative review focusing on patient safety in these settings. I first of all started by trying to conduct a systematic scoping review, but found that there were too many challenges in trying to kind of conceptualize what counted as a patient safety problem in this context, where there are there's very limited literature which is kind of explicitly reporting on patient safety challenges in this setting. So I really felt like I was having to make the decision about what counted as a safety relevant problem. And it didn't feel like the field was quite ready to jump into that kind of a structured review at that point. So I took a step back, and this narrative review evolved in a more organic way. And I sought to write about the state of patient safety in mental health care, but also kind of conceptual and practical issues in this research area. And I had to borrow lots of literature from other areas of the evidence base, given the lack of research in community-based mental health services specifically. So I had to borrow literature from kind of improvement science, the wider field of patient safety, inpatient mental health services, and physical healthcare, where we have a much more mature evidence base. So to start with, it might be helpful to think about the problem that we're trying to define. So this is a well-cited definition of patient safety from the US Agency for Healthcare Research and Quality. So patient safety as freedom from accidental or preventable injuries produced by medical care. And this has a number of problems when we think about it in the context of mental health services. So starting with injuries, it really doesn't consider the other types of iatrogenic harm, which we know are very widespread in mental health care. For example, psychological impacts of compulsory care, which is a bit of a mainstay of mental health services. The language of produced by is also quite problematic in this setting because it doesn't really capture those problems which we know service users, their families, and clinicians are particularly worried about. So some of the ones I've already mentioned, such as self-harm or rare acts of violence and aggression. It doesn't really feel like it fits well within this kind of terminology. And lastly, medical care. One of the key things that people wanted to emphasize to me in the interviews and focus groups that we conducted, that actually a huge part of staying safe in mental health care is about that therapeutic relationship with a care coordinator or another key member of staff. And this definition doesn't seem to really cover these kind of issues. But it becomes even more complex when we think about patient safety outside of the hospital setting. So in terms of what counts as a relevant patient safety problem, you could ask questions such as, does an incident of self-harm in a service user's own home, which isn't observed by staff, does that count as a relevant patient safety incident and something that should be reported? And that was something that I had quite different responses from staff about when speaking to them. So some other kind of conclusions from this paper, simply that when we look beyond the hospital setting, patient safety measurement, but also intervention becomes a lot more complex. And this isn't specific to mental health services. This is likely true of all kind of community-based care, really. We just don't have the same robust patient safety indicators in quite the same way, although there's definitely work being undertaken to develop this, which is obviously very welcome. Community care episodes are typically much longer term, but kind of lower frequency of care encounters. So it might be the case that someone under community mental health services might see their psychiatrist once every 3 months, or a care coordinator, once a month. So it's a much lower intensity when we compare to kind of acute inpatient mental health services. There's, of course, limited control over external factors that have impacts on patient safety, such as the safety of the home environment, particularly where people are living in kind of supported accommodation settings with other people who are quite unwell as well. There's the fact that there's input from multiple care providers, who all may be prescribing different medications, and there's no one person that's responsible for all of those problems and potential interactions. Of course, there's the monitoring of either stable or deteriorating illnesses over time, which can be quite different to, for example, an acute episode of an illness treated in an inpatient setting. So all of these really lead us to the question of, what counts as a kind of preventable patient safety problem in community-based mental health care? And I think the jury is probably still out on that one. So this work led me into a systematic scoping review, which sought to understand the kind of nature and prevalence of patient safety problems in community-based mental health services in a much more systematic way. I'm currently updating the review with the help from Isabel Baker, who is from Yorkshire Quality and Safety Research. So really glad to have her support with that. As part of the review, I mapped the contributory factors to the Yorkshire Contributory Factors Framework, the mental health adaptation. And I'll just give an overview of some of the findings from the first round of the review prior to the current update. So there were quite a few studies which were in scope, although they were of mixed quality. And I think the thing that was most challenging was that the literature found very rarely contextualized itself in terms of patient safety, very rarely drew upon kind of relevant patient safety terminology or evidence. And I suppose this is more of more recognition of the fact that the fields of patient safety and mental health services research have really developed quite separately. There were 7 main kind of categories of research, some around the risk management issues that we've already discussed, so around risks of harm to self or violence and aggression, but also important factors around assessment and decision making and medication safety, communication issues, and safety of the care system, which was really about the culture of safety, but also the sense of whether people felt safe or not within services. So a couple of the key findings. In general, there was quite limited reflection on either causes or contributory factors to patient safety problems within the literature. Where there was some kind of explicit discussion of these issues, local working conditions such as excessive staff workload or issues with unclear lines of responsibility were key issues. So with the lines of responsibility, I think a key area of literature that came out in is confusion between GPs and community mental health teams over who should be monitoring potential risks associated with mental health medications. Even with shared care agreements, there was still a sense that it was not always clear who should be taking on this work. And then to move on to the next key studies, I really sought to triangulate what was in the existing literature with what could be learnt from patient safety incident report data. So for those that are unfamiliar with our incident reporting systems, the data that I used were from the National Reporting and Learning System, the NRLS. And the process here is that people report incidents within their service locally, and then these are uploaded to a national system. Since writing this up, we have a new incident reporting system within England, but these data weren't available at the time that I was developing this study. So within these reports, healthcare professionals are asked to kind of give a rating or a judgment of the level of harm caused by the patient safety incident. And this ranges from no harm to death of a patient. And within these analyses, again, I was aiming to understand, what are the key patient safety problems according to healthcare professionals, but also what are the solutions that staff identify as being potentially relevant for preventing a recurrence of these incidents. It's quite challenging to identify a relevant sample within this database because many of the kind of structured fields for healthcare setting don't align very well with community-based care settings. So this was quite an iterative approach to define the sample. but I will talk you through some of the findings. So perhaps unsurprisingly, for each incident type, patient safety incidents related to risk management were the most commonly reported. So that's at every level of harm, from no harm, low harm, and moderate harm. Self-harm was most widely reported. And then when we looked at severe harm, attempted suicides were the most reported incidents. And then under patient deaths, it was suicides were the modal incident types. I think the contributory factors were quite diverse, and again, situational failures such as team function problems and local working conditions came out as being problematic in causing or contributing to incidents. And I think another key point is that the solutions that the incident reporters were raising were generally quite poorly aligned with their own assessment of how the incident had occurred and why the incident had occurred. So, we saw the kind of typical suggestion that staff needed more training, or there needed to be different policies developed, or policies to be revised, but there was kind of no indication within the reports that incidents were contributed to by a deficit in training or availability of policy documents. I think to move away from the kind of top level findings and consider some of the other findings that were reasonably interesting in this context. Diagnosis and assessment related incidents made up a huge proportion of the moderate harm incidents, so over 1/3, which I think was quite a surprising finding for us. And the vast majority of these incidents related to delayed Mental Health Act assessments. And for those that aren't familiar with the process of arranging a Mental Health Act assessment, it can be quite fraught. It's quite a challenging process. So you need to have an AMP, that's an approved mental health professional, the police, psychiatrist, and a hospital bed that's available, all kind of lined up at the same time. And that can prove very, very challenging in practice. So what we were seeing amongst these data is that Mental Health Act assessments are frequently delayed or cancelled. And what this means is that, service users that are potentially at very high risk of harm are in the community, potentially at home with family members, and in a very, very vulnerable position all the while they are awaiting this assessment. So I think some of the quotes from incident reporters really illustrate this. So this report, for example, I actually find it quite hard to read. I think it's quite upsetting to see the level of stress amongst clinical teams, but also for the service users and families involved. So we're failing to do our most basic duty as a community team, namely to admit a person with schizophrenia who's relapsed and is too ill to accept informal approaches. We're failing this patient, his community, and the wider public. There's a high risk that he will come to physical harm or someone close to him will. And beyond those kind of specialty-specific challenges, we also saw lots of the kind of everyday commonplace incidents that you would expect to see from any healthcare setting, such as documentation and communication errors. But I think what's interesting is that you can see from some of these quotes how, everyday commonplace problems can have actually quite severe and potentially long-lasting impacts. So this report relates to the medication clozapine, which can be a very effective antipsychotic for some people, but it's closely controlled because it can also have quite severe patient safety consequences. So in order to be prescribed with clozapine, service users need to have regular blood testing to check that they are responding to it safely, essentially. And the kind of upshot of that is that if these tests aren't documented, pharmacists and prescribers are unable to issue the medication, which means that people end up having a break in their medication and then need to be retitrated on it, which can lead to quite serious consequences. So we can see in this example, the service user that they are speaking about had taken a year to be stabilised on their medication in an inpatient setting. And we can really see the disruption that everyday errors can cause to people's lives, and the kind of impacts for service users and their families. And this brings me on to the last main study that I carried out, which was a qualitative interview and focus group study. And this work was really, again, seeking to understand the kind of the nature of the problems, and priorities for improving care, but also to understand, what safe and unsafe care looks like to service users, carers, and staff using these services or working in these services. Because, as I mentioned, there's not really a clear idea of how this is conceptualized by those using or interacting with services. An important part of this work was to make sure that seldom heard communities were included in the project, particularly people with severe mental illness, but also people from a range of ethnic backgrounds, to make sure that we were reaching a wide range of communities when we were seeking to understand what the problems are and people's perspectives on this. So there was quite a long recruitment period for this study to make sure that a range of perspectives were gathered. These data were analysed with reflexive statistical analysis. And I'll just go through a few of the findings. So very excitingly, the paper actually got published overnight. So I've shamelessly plugged it in the right-hand side of the slide there. But there were 4 main themes from the analysis, which I'll go into in a little bit of detail. So the 4 key themes related to how people conceptualize safe or unsafe care in the context of community-based mental health services. And these themes, they're not mutually exclusive, and often people's conceptualization kind of evolved throughout the discussion, and people espouse views which related to more than one of these themes. So the first theme really recognizes the systemic challenges that staff inherit in their daily work within community-based mental health services. And these conditions are such that care routinely departs from safe practice. It's common. It's not the exception to the norm. And some of the key issues within this theme were around access, in terms of accessing crisis care or out of hours care, and the challenges that people face throughout that pathway. And even once people were in services, that wasn't really the end of their problems. There could often be waits of around a year to access psychological therapies, 2 years for autism assessments. And all of these problems meant that people were left in a situation where they were deteriorating, and not able to fulfill their lives and do the things they wanted to do. Falling through the gaps is another related issue, and this related to particular groups of service users. So typically there weren't appropriate services available for people with a personality disorder diagnosis, and also those service users whose needs were not considered to be quite at the threshold of secondary care services, but to be considered to be too unwell for IAPT services, which are improving access to psychological therapy. And what this meant is that there were, vast groups of service users for whom no service was available at all, which of course it's just not really acceptable. And there were issues around the workforce and underinvestment. So there was a sense that there was a decline in the seniority and experience within clinical teams. There's obviously high turnover, and less of that kind of senior clinical experience to draw on, which was very, very difficult for kind of new starters, or people that are newly qualified. There were issues around policies and procedures, and how staff had to use workarounds to make sure that they could actually deliver their jobs properly. So things such as lone working policies, they're obviously designed to keep staff safe, but in reality, if staff were trying to wait for another member of their team to come and do a home visit for a service user, it simply wasn't going to happen. So routinely they found that they were having to to work around these rules essentially to get their jobs done. In terms of policies and procedures, the Mental Health Act process came up again. I think staff felt very frustrated, and family carers felt very frustrated too, that there was a sense that you had to wait for someone to become extremely unwell if they were declining kind of informal approaches to care. So it's almost like you had to let that deterioration happen before you could then, use the Mental Health Act to provide someone with care. And that was a real challenge that was described in multiple interviews. So I think there was a real sense of time and the issues relating to time and what happens when people can't access the care that they need and when they need it. And there's also a sense that, around falling through the gaps, that because services are so stressed and stretched, people, use quite tight criteria about what counts as, as falling within a service's remit. And another group that this really impacts in terms of mental health services is people with a primary mental health problem, but also a comorbid substance issue, which is actually quite a high proportion of people. And neither mental health services nor substance use services were necessarily taking on some of these patients, which left them without any support at all. A second key theme really draws on those kind of risk management issues, which I've spoken about at multiple points in the presentation. And again, it really goes back to that kind of dominant narrative of what safety in mental health care looks like. And of course, it's a bit less progressive, but it is still an important part of what people consider to be safety relevant in this context. So it's quite interesting to see how some of the staff spoke about, unsafe mental health care. They spoke about it directly in the terms of service users being unsafe. And again, it's an important part of people's considerations of what counts as kind of safe care in this context. But again, we need to make sure that we're not just focused on this kind of theme and topic at the expense of other areas. A third theme was more progressive and really takes into account that whilst we have those kind of systemic problems that staff are working with when they're trying to deliver care, and we're also working with service users and their risks when unwell, there is also a sense that healthcare providers do have agency to either cause or prevent harm in this context. So this was really more aligned with kind of safety two approaches. How can we build in mechanisms to prevent harm? So this quote from a service user really recognises some of the kind of psychological harms associated with care and the way that care is delivered. But then, as I mentioned, there's also the recognition that, whilst the daily conditions are very difficult, there is potentially something that we can do about this. We can begin to build in checks earlier on. We can kind of strengthen our systems to try and make sure that the care that is delivered is safer. And lastly, the final theme really recognises that patient safety improvement agendas have been quite limited thus far, and seldom really consider those goals that are meaningful to service users. So, what constitutes harm might look a little bit different depending on the perspective. So we really got a sense that people felt that whilst, services may not be causing people direct harm, by focusing on stabilizing someone on their medication alone as the endpoint of mental health care, people really felt like that was neither suitable nor ethical. There was a real sense that we need to work towards goals that are actually meaningful to service users in terms of, maybe rebuilding their lives after an acute period of mental illness and working towards the goals that help people to stay safe, be it, employment or other things that bring meaning to people's lives. So some conclusions, and these are just some top-level summaries from all of the studies, and I'm sure that I've missed things, so please let me know if I've missed anything important at the end. But In terms of the nature of the beast, what are the problems in this care context? Of course, risk management issues are really important to consider when, understanding or improving patient safety in this context. So risks of self-harm and suicide. And when we think about community care, also risks of self-neglect for people that are being cared for maybe in their own home, are having infrequent, care visits, becomes a really important one. There was also a sense that some of the risk assessment tools used in mental health services lack the kind of predictive validity that may be needed to actually kind of understand risk and improve safety. Access and transitions became a really key one, and the issues that people face in accessing the care that they need and when they need it, be it crisis care or out-of-hours care. For many people, turning up to an emergency department is the only thing that is available for them out of hours, and this was widely felt to be, inadequate and potentially to make people feel worse and potentially to make the situation more unsafe. Again, some of the issues I've already mentioned around the issues that people face even once they're in services, in accessing the kind of psychological therapies or assessments that they need, and the challenges in arranging care under the Mental Health Act and lining up all those key players in that process. Medication, and I haven't really gone into this too much today, but there were lots of challenges around medication errors and prescribing safety issues, but also the gaps in the monitoring of medications and side effects. So we know that antipsychotics can have quite a heavy burden on people in terms of risks and side effects. And there was a real sense that there needed to be kind of an improvement in clinical teams in terms of recognition and monitoring, but also managing these issues. Communication, the key issues that you experience in kind of any healthcare setting around information sharing within and between teams. And this is, of course, made worse with the lack of interoperability between our different electronic health record systems. And this comes to a head again in the community when we're thinking about people that are under multiple services potentially. Feeling safe was a really important one. So there was a real sense from service users of stigma, particularly for certain diagnoses such as personality disorder diagnoses, and feeling processed or not feeling cared for in the way that they would like to be. Issues around the organisation of care, so how services manage their kind of caseloads and how they address things such as staffing changes and long-term absences. And we know that that has been involved in many serious incidents. And again, kind of issues where people are discharged if they're not attending multiple appointments in a row. We know that that's something that happens often in community mental health services, despite the fact that it shouldn't necessarily happen in that way, and that should be a sign that potentially risk is increasing or someone is getting more unwell. And then lastly, priorities for improving safety. There was a real sense that we need to develop environments in which people feel safe. And we know that psychological aspects of safety are often overlooked as we think about physical safety in mental health care. The importance of compassionate interactions between providers and service users. Many service users that I spoke to said that after self-harm or a suicide attempt, the only kind of interaction they had with healthcare providers was to sort of stitch up a wound, and there was no sense of trying to understand what kind of problems have actually led to someone feeling in this way. A real focus on medication safety again. There was a sense that there needs to be a real joined up approach in mental health care to medication optimization and deprescribing, where people were on long lists of medication which were interacting with one another and causing people the types of side effects that made them want to discontinue their medications. Collaboration with carers on risk and safety. I think this becomes really important in the community where family carers are living with a service user but feel like they're not involved in those important discussions about risk and safety, even though often, particularly in rare cases where people are, aggressive when unwell, it's usually carers that take on the brunt of that, but they didn't feel included in those important forums. Something around improving service resilience and taking kind of a proactive and preventative approach to safety. And there were some important ideas that came out around that, but there was recognition that, of course, staffing issues and staff workload are real threats to actually enacting those. And then improving patient flow. Are there ways in which we can reduce those delays to people entering and moving between services, where it's often those delays that cause people to get much more unwell and then to have many more problems that need to be addressed by services. And then lastly, around optimizing staffing and skills mix, and ensuring that we have, kind of a suitable range of skills within the team and, suitable supervision of junior clinicians as well. So thanks very much for listening. I appreciate that was a lot of information. Special thanks to this institute for generously funding this research, and of course the service users and carers and staff that were really generous with their time for this project. And a big thanks to co-authors and collaborators, so Professors Claire Henderson, Nick Sevdalis, Charles Vincent, Dr. Gurpreet Reen, and Isabel Baker for all their help with this work. And thanks for listening as well.
That's fantastic. Thanks so much for that, Phoebe. That was really fascinating and eye-opening about the prominent challenges that arise in community mental health care settings. It feels so important carrying out this research in an area that's been so under-researched in the past. So we have a few questions in the chat that I'll just read out, but if anyone has any other questions, please do feel free to pop them in the chat. So the first question we have is from Hannah Sharp, and it is, I work with NHSE on their CYPMH service redesign, and we're currently looking at identifying what metrics we can use to give an early indication that a service could be becoming unsafe. Sorry, I can't quite read that word. It's both community and inpatient. I wondered if anything measurable jumped out in your research that seemed to indicate that serious issues may be emerging.
It's a really good question. Thank you. Of course, I have to point out that I focused on working age adults as part of this research, but that's not to say that there aren't things that can be generalized to children and young people as well. I suppose, I think in the community, I suppose the key issues of a service being unsafe, I suppose, is when you get really long waiting lists, which I know is raised in every report into patient safety. And I think in inpatient settings, again, I suppose it's around people feeling safe, and often it's around those relationships with staff as well, and whether people feel able to open up to staff if they, for example, feel at risk of self-harming or whatever it may be. So I suppose it's about, the cultures of inpatient settings, which can often be very, traumatizing for, young people, but also for adults using adult services. Again, in terms of metrics, it becomes very challenging. But I do think there are some good, patient-reported measures being developed. And I know there's some work at Leeds University as well around kind of real-time monitoring of how safe people feel in inpatient mental health care settings, which will be really interesting to see the findings of when that work is out there. But I'm sorry I can't answer your question more thoroughly.
Great, thank you, Phoebe. The second question in the chat is from Debbie, and she mentions that you mentioned workarounds. Was there any evidence in the data that workarounds were contributing to safety at certain times? And if so, how are these managed?
Yeah, it's very challenging. I think a lot of it was anecdotal from staff, I suppose in an interview slightly more off the record, mentioning that's what they were having to do in their day-to-day practice. I think there was some evidence of that in the incident report data, in that there was a lot of talk about people having to take on caseloads which were actually larger than they were even allowed to accept, and how they managed that, or student nurses used for tasks which, you know, when they were meant to be supernumerary. It's difficult to have those to find those clear links in the data around kind of, I guess, cause and effect on that. But there was definitely a sense that you know, the service wouldn't manage and wouldn't be able to operate if they were performing according to, you know, the rules as set out every day.
Thanks, Phoebe. Another question from Ed. Ed says, thanks for a great presentation, Phoebe, and congrats on the publication. You had a diverse population for your qualitative study. Did you find any themes around inequities in safety based on ethnicity, etc.?
Yes, thank you for bringing that up. Yes, certainly. There was a real sense amongst clinicians, but also service users and carers, that families from Black backgrounds and service users from Black backgrounds were really experiencing, you know, the poorest quality care, and were most likely to experience coercive measures such as community treatment orders, which are, as many of you will be aware, where service users can be recalled to hospital if they don't meet certain conditions of their order, such as meeting their care coordinator however many times a week and receiving medication. So there was a real sense that these kind of coercive measures were used more so with families from Black backgrounds, but that psychological therapies were made less available to these service users. I think, interestingly, a finding that I hadn't really come across before was that there was a sense from I'm thinking about one carer that I spoke to who really felt that as an Asian woman, her sister was very much overlooked by community mental health services because they felt like she wasn't a risk to herself or other people. So what that meant was that she was just sort of left to deteriorate, really, and she wasn't getting the kind of input that her family felt that she needed. They felt that she actually did need to be detained under the Mental Health Act so that she could receive the care that she needed to become well again and kind of regain that insight. So that was interesting and unexpected as well.
Thanks, Phoebe. Matt asks, you mentioned increased risk with comorbidities of substance misuse and personality disorder. Was there any correlation to this with learning disabilities and ASD diagnosis?
Yeah, it's a really good question. I think it definitely came up in some of the literature that I was looking at, but was somewhat beyond the scope of what I was able to cover with this research. But it's certainly very interesting and needs a lot more exploration.
Thanks, Phoebe. So there aren't any more questions in the chat, but if anyone has any other questions, if you just want to raise your hand, or you can just jump in.
Can I ask a question?
Please go ahead.
When you were talking to people, service users, patients, did they talk about those that are there to support them on a sort of mental health recovery journey during the sort of mental health, ill health? Did they talk about people not looking like them? Was that raised as an issue?
Is that, sorry, in the context of, are we thinking about service use in general, or are we going back to the earlier question? It's a good point. I think people really felt like they related to their peer support workers where they had one, which was interesting and not surprising that people found that to be a really valuable resource to them. I'm not so sure about. I'm not sure about whether that was another issue. It might just simply be that because there was so much ground to cover that we didn't really have the opportunity to explore that, but it's certainly interesting.
Yeah, I mean, it is linked to that peer support. I mean, I made videos where people record their experience, and they actually said many of the things you said about that need for compassionate, understanding, people that understand me, and particularly about people that want to get to know me. Those are the important ingredients. But yeah, really good, really good, really. I used to work in community mental health transformation.
Okay.
So, yeah.
Thank you. No, that's really interesting.
Thanks, Gary. So are there any other questions at all from anyone? No, I can't see any other hands. So I think if there's no other questions, are we okay to leave it there, Debbie? Is that okay? So everyone can go and have lunch. But yeah, so just say thank you so much again, Phoebe. That was a really, really fantastic talk. And thank you for attending, everyone. Debbie, is there anything you'd like to add?
No, not at all. Just to thank you, Phoebe. That's been a really great, insightful talk. Thank you very much.
Yeah.
For having me, and thanks to Prof. Lawton as well for the invite.
Thanks, Phoebe.
Thank you.
Thanks, everyone. Goodbye.
Thanks all.